Hello, everyone. Thanks for joining today. So I'm Matt Negaard. So I'm an emergency medicine physician as well as a sports medicine physician, and we're going to be talking about exertional heat illness today briefly. As I mentioned, I'm an ER doc, so hopefully I'll do this relatively quickly and get moving on to the rest of your day. Okay. So I don't have any disclosures. So just a little bit about me. So I was born in Pennsylvania, but grew up in Iowa. Went to a small school for undergrad and then did all of my medical training at the University of Iowa. It's where I met my now wife, Brianna. She was in an undergrad there at the time and then went to pharmacy school there. We have a brand new baby, Madeline, that's 5 weeks old, and Bella, our dog, is about it's 2.5 now. So, so like I said, I did emergency medicine residency, and then I did a sports medicine fellowship. I'm still on at faculty at the University of Iowa at the emergency department, and I work there a little bit. And then here at Forté, I see a lot of patients, non-operative patients, kind of run our walk-in clinic here, and then I do a lot of musculoskeletal ultrasound injections, and orthobiologics, including PRP, shockwave therapy, that type of thing. This will be my 4th football season with Heritage Christian as a team physician there, and then be my 2nd year with Indianapolis Colts coming up. So pretty wide range of things, I guess. So when we look at the spectrum of heat illness, right, so there's this spectrum from just having some heat cramps, which we've all experienced. Could also go on a talk about heat cramps and the true etiology of why they're happening. It's probably more secondary to neuromuscular fatigue rather than the electrolyte imbalances that we often attribute it to. If you really want to think about it, the thing that works all the time is stretching, right? And so that's it's neuromuscular control rather than generally electrolyte imbalances, but that's a whole nother topic that you can ask me about if you want it sometime. So, and then as we progress into the more severity of illness, we get heat syncope. This is usually a result of pooling of blood and just getting hypovolemic, just like hypovolemic syncope as well. So usually this resolves relatively quickly. You can think of some sports that occur in Terre Haute that may have that happen quite a bit towards the end of the race. Then as we move on, we get heat exhaustion. So heat exhaustion, you're starting to get some more kind of physiologic depriments that are causing more problems. So your body is exerting itself too much than it's used to. And then at the tail end of it is heat stroke, right? And so heat stroke, you're going to have significant hyperthermia, but then the biggest difference is you're going to have some central nervous symptoms, central nervous dysfunction at that point. When we really look more closely at the difference between heat exhaustion and heat stroke, typically heat stroke is seen greater than temperature of 104 degrees or 40 degrees Celsius, then you're going to have some sort of CNS dysfunction. There are studies looking at athletes that have rectal temperatures nearly to 42 degrees Celsius, but they don't have any signs or symptoms. So it's important to not just go by the temperature, but go by that really they have some central nervous system dysfunction or some other symptoms in addition to that high temperature. Temperature alone does not mean that they have heat stroke. And so epidemiology of heat illness. So again, this won't work. High incident of heat illness in competition. So and remember, heat illness is that spectrum that we just talked about. So the correct answer here is girls cross country. So girls cross country has the highest competition exertional heat illness. Most of that is attributed to that heat syncope. You see that at least in the literature, I think it's probably due to collapse that happens at the end of a race from pooling of the blood. But nonetheless, that's the answer. But heat illness in general is one of the leading causes of non-cardiac deaths in athletes. It's 15% of all football-related deaths, which is significantly high, and 2% of all sport-related deaths. Nearly 9,000 high school athletes a year are having some sort of heat illness. Football is traditionally what I think about as the most common. It has to do with timing of the year and weather and pads and all of that. But football has the highest overall practice and competition rate of heat illness. You can see there's been 68 deaths since the mid-90s. Most of these are occurring in our high school athletes. You'll see that most of these, incidents of this happens in August. Has to do with temperature, has to do with people being deconditioned, etc. And then most of these are happening when practices last longer than 3 hours. Okay, up to a third of heat stroke are happening when football practice is lasting greater than 2 hours, but even 3 hours significantly increases the risk of heat stroke. So a lot of the guidelines and recommendations are not to have practice greater than 2 or 3 hours without a break in between. So how do we recognize it? We've kind of talked about this quite a bit, but usually you're going to see some sort of CNS type of symptoms, whether it's clumsiness, stumbling, just not making sense, nausea, just not feeling right. Those should all trigger you to check a temperature. And checking a temperature in this situation is a rectal temperature. Temperature at the skin or under the armpit or in the mouth, things like that, should not be used at any time to diagnose heat stroke or heat exhaustion. Or so if you are thinking about that this is what's going on, it needs to be a rectal temperature. And so part of that is having the equipment available to you to be able to do that. Moving on to management. So true, false question. Athlete is suffering from a heat stroke. Most important action is transport them to the nearest emergency department as quickly as possible. Just put in the chat true or false. All right, so it's actually false. So the biggest thing is to cool them. Okay, cool them as quickly as possible. And when EMS arrives, we should still cool them before transport. So this is going to deviate from traditional EMS response of that they are going to want to load and go quickly. But this actually is detrimental. There was actually I believe it was in Florida, there was a high school athlete who the 911 call even told them to transport and not to cool the patient too quickly, which is completely false. You can't cool them too quickly. So want to cool them as quickly as possible and get them down to less than 39 degrees or 102 degrees before you transport, before you remove them from any cooling. And so the best, so this is on this line, this kind of chart is from the Journal of Athletic Training. So, athlete collapses during exercise. The first thing is this, atraumatic collapse is this cardiac, right? That's the first thing that you need to do. So run out there, check vital signs. Okay, they're breathing. You even put an AED on, no shock. They have a pulse. Okay, move on. All right, the situation seems like it could be heat illness. So you're checking a rectal temperature and then cooling them as quickly as possible. In this algorithm, in the method of cooling, it should be total body immersion. Okay, should be cold water with ice, and then having people bring you ice to cool it, continue to cool that water as possible. So we know that total body immersion or whole body immersion is by far the best method. It's been associated within 30 minutes of collapse of getting them cooled down. There's a 0% mortality reported in the literature. So that initial time period that you guys are going to be involved in is significantly important. Okay. As we and I said we're going to cool to a temperature of less than 39 or 102. If the probe falls out and you can't get it back in or whatever, and you can't monitor, a lot of times people will say cool them to mental status changes. So if their mentation starts to improve, if you can't get a rectal temperature for whatever reason, if their mental status starts to improve, then you can transport after that. In this algorithm, they talk about removing layers of clothing and equipment. There's actually a couple studies looking at cooling football players in particular with helmet and shoulder pads on, and they do well. So the most important thing is to actually get them cooled. So if it's going to be a hassle to get their equipment off, that's fine. Dunk them, put them in the water, then while they're in there, start taking off all their stuff. They're traditionally was concerned about shivering, but we really don't worry about that too much. Okay, a lot of the shivering studies are in, or people looking at shivering and things were in conscious volunteers that did this, and so we know that people that are altered and have exertional heat stroke often has less shivering than in the studies with these healthy volunteers, and plus the amount of heat that's given off by shivering is very minimal compared to what you're gaining from keeping them in an ice bath. So again, this chart is looking at the different methods of cooling and how fast they cool, and as we talked about, ice water, cold water, immersion is by far the best. So the important part about this is it does require pre-planning, right? So if you're not prepared to do this, it's not going to happen, and there's significant increased morbidity and mortality from it. So being prepared is the best thing that you can do for this. And so that means having a tank, or if you don't have a feed trough, then get a tarp. And then especially if you have multiple sports going on at multiple different sites, which I know the fall is usually crazy, where there could be multiple fields going on at multiple different locations. So around campus. So there needs to be a plan for at each of those locations. And whatever best suits you guys and your resources, but whatever that is, that needs to be ironed out before. Again, some sort of neck down is best, and you can put a towel under their arms, wrap it around their chest, and hold them up. That way is kind of the best way to go. Packing the axilla, neck, and groin hasn't really been shown to, or has been shown that it really has no benefit over passive cooling, so would avoid those. But actually, cheeks, palms, and soles are better than those aforementioned areas. So if you can't, for whatever reason, you're just in a situation where the immersion isn't possible, cheeks, palms, and soles is the way to go. And so remember, time is brain at this point, and if they're altered and have a temperature, their brain is frying. So we need to cool them and then transport them. Okay, the best thing is to cool them as rapidly, as quickly as possible. One of the biggest things is, I'm preaching to the choir here, but having access to athletic trainers and having athletic trainers on site is one of the biggest things that can help help have good outcomes when this happens, or even prevent this from happening. Being aware of the risk factors for this. So Corey Stringer Institute puts out these acclimation policies and things like that. The state of Florida has ones too. Georgia has one. So different states will have different ones and different guidelines on how to wean these athletes into activity to try to have them be more acclimated to the environment. The other thing that we've kind of mentioned a little bit is having an emergency action plan, and then along with that, have a plan for cold water immersion. This may also be a discussion with local EMS and local EMS medical directors on their policy of when you're going to transport that patient. If you're dunking them, they need to stay there until their core body temperature cools down. This is well supported in the emergency medicine literature, but it may not be in local EMS protocols. And the last thing you want to do is start fighting on scene of these kind of critical situations. So if you know what EMS crew you're going to be working with in your environment, I would suggest reaching out to them, asking them what their protocols are, and then making sure that everyone is on the same page. If their policy is currently to transport, I would ask to have a discussion with their medical director on getting that policy changed, because ultimately save lives. All right, so other things is looking at, we've all heard of the wet bulb globe temperature, and so that takes into account humidity, radiant heat, ambient temperature to give you this other temperature, and then there's different guidelines based on how much activity is appropriate based on this temperature. The thought behind it is that as the environment temperature increases and the wet bulb globe temperature increases, the time to exhaustion decreases, and your energy stores have a faster depletion with temperature control. The issue with all these guidelines is it doesn't take into account regional variation and acclimatization. So there's a study out of Florida that looked at if they would follow the ACMS guidelines for this, their athletes would not be able to participate in nearly 90% of days in the summer and fall, which makes no sense, right? So you have to take into account that regional variation and where you're at. So for here, you just have to, talk to your athletic director, talk to your team physician about what your policy is going to be in our area, in our kind of weather environment. Yeah. So also understanding risk factors here. So dehydration is actually one of the biggest risk factors. Okay, so reduces exercise performance, as we know, decreases time to exhaustion, but it also increases heat storage. So you have decreased volume, decreased blood flow to muscle and skin, which leads to decreased heat dissipation, which leads to increase in core body temperature. So on the chart over here, there's the table. So the lower line is someone who is heat acclimated and euvolemic, so they're not dehydrated, and you can see how their core body temperature, it goes up, but it stays relatively low. Now, as we talked about, being acclimated is important as well, but if you're unacclimated, you can see how that's the middle line, unacclimated, euvolemic, their core body temperature still goes up quite a bit. Goes up more than if someone is already acclimated, but they're still euvolemic, so it doesn't go up as much. Now, the top line is someone who is either acclimated or not acclimated, but is hypovolemic or dehydrated. You can see how their core body temperature significantly increases with exercise. So being hydrated before is a significantly important thing to help prevent heat illness. So also being aware of medications. So ADHD meds are a significant risk factor for having heat stroke and heat exhaustion due to the thermoregulation that so they're stimulant. Most of them are stimulant medications. So caffeine, all these pre-workouts that everyone's drinking all the time before practice and before games, those will increase your risk of heat illness. So be aware on hot days if kids are taking that. Febrile illness. So most patients that have heat stroke report a recent febrile illness. Okay, so if someone has a fever or is sick or has a cough, they should not participate regardless, but even especially should not participate if there's a heat illness. Also understanding your patient population, that sickle cell trait has a significant increased risk of heat illness and heat syncope, as well as multiple other complications. So being aware of your athletes, as well as your coaches that have sickle cell trait, is going to be significantly important. So identifying them, they have a higher risk of suffering from this, and they require different treatment and require aggressive volume resuscitation as well in the emergency department. So if you know that someone has sickle cell trait and is endorsing some of these symptoms, I would have a lower threshold to send them to the emergency department. Everyone with heat stroke needs to go to the emergency department, but the heat exhaustion type of symptoms were not altered, but they're just unproportionately tired or just endorsing that they don't feel right. I have a lower threshold to send that patient to the emergency department. So I always like to provide you with some recommended reading and resources. So this is a consensus statement of pre-hospital care of exertional heat and illness, mainly written by a bunch of athletic trainers and sports medicine physicians. And so it's relatively quick. I think it's like 4 or 5 pages, so it's not terrible. But that is if you're going to read one thing, I would read that to kind of have a good overview of everything. Additionally, the IHSAA has some resources online for you, particularly heat illness. You can see here on the website that there are some nice resources there for you as well.